Great. So good morning, good afternoon, good evening, everyone. You are all very welcome, and we're excited to have you join us for this session. Before we get started, we'll just go over a few housekeeping and logistics for the workshop. So the structure of the workshop today, we've planned to have this workshop in 3 different parts. First, we'll listen to some presentations. Then we will have a panel discussion, and then we'll open the floor for questions and answers. However, you can definitely ask questions throughout the session. You don't need to wait until the Q&A portion, which will be at the end. There will be lots of time to contribute, and as you can see on the screen, you will be able to see there's multiple ways to participate. So you can mute and unmute your microphone, which you can see at the bottom left of your screen. You can also turn on and off the video, so when we do call on you to make your comment or question, we would love to see your face if possible, and of course you'll need to unmute yourself during that time. Now, the way to submit questions are through the chat function on the virtual meeting platform, which hopefully everyone is familiar with now since you were able to join this virtual session. So you'll find this by going to the agenda tab, clicking on this session, mainstreaming GESI into health system strengthening for NTDs. And then you'll be able to just click on the chat, and myself and my colleague Paula will be monitoring the chat function the entire time. And then we will try to get through all of the questions, but if not, we will be sure to save all the questions, and the presenters will go through them, and hopefully we can find a way to respond after the session. I forgot to introduce myself. My name is Amanda Otteson. I am a program officer with WIHER. And with all of that covered, I would love to invite our moderator of today's session, Mr. Teshale Yadeta, who is a public health expert with over 15 years of experience. He's a health system strengthening advisor for RTI and the USAID Act to End NTDs project, the Act to End NTDs East project, and currently in Ethiopia. So with that, Mr. Teshale, over to you.
Thank you so much, Amanda. Welcome everyone to this NNN Conference 2020, Accelerating to 2030, Building Resilient NTD Program in a Changing World. We will have a session today, mainstreaming gender equity and the social inclusion into health system strengthening for NTDs. And we will see case studies in Nepal, Tanzania, and Uganda. The objectives of today's session are: 1 is sharing lessons learned from 3 countries on gender equity and the social inclusion dynamics and how they affect NTD program across the globe. The second objective is just realizing how gender equity and the social inclusion can strengthen NTD programming in order to reach the last mile. And the last one is to explore challenges and opportunities in Uganda, Tanzania, and Nepal to mainstream and integrate gender equity and the social inclusion. So for today's panel session, we'll have 4 presenters. Dr. Tarub, founder and the president of Women Influencing Health, Education and the Rule of Law, partner on USAID's Act to End NTDs East program at global level. And the second presenter will be Mr. Darpan Prasad Raman, Chief of Party Act East Nepal. And the third presenter will be Dr. Wembley Anderson Mutini, Health System Strengthening Advisor Act East Tanzania. And the last presenter will be Mr. Mike Mukrani, Health System Strengthening Advisor, Act East, Uganda. And as Amanda said, I am a moderator for today's session. So before actually going to today's session, can I get the second slide, the next slide, Amanda? Yeah, thank you so much. So here is countries where active in the NTD East is working. As you can see, the orange shaded ones are where active in the NTD is operating. So the USAID's active in the NTD East program is supporting national governments to reach their NTD elimination goals and helping to create sustainable NTD programming with robust and resilient health systems. ACT East works in 13 countries across 5 NTDs, including onchocerciasis, lymphatic filariasis, soil-transmitted helminths, trachoma, and schistosomiasis that can all be targeted by distributing preventive chemotherapy to population living in endemic areas. This is the overview of what we are currently working. So now I am inviting Dr. Taro, who will be starting our presentation, and we'll be hearing from Dr. Taroub, the general overview of gender equity and the social inclusion in the lens of NTD program. So Dr. Taroub, you can continue your presentation.
Thank you, Tishale. Good morning, good afternoon, everyone. And thank you for joining us today for this important event. As Tishale mentioned, ACT to End Neglected Tropical Diseases project is funded by USAID and is led by RTI International. RTI have been doing outstanding work and is a global leader in addressing neglected tropical diseases. YHER is a partner on the ACT to End Neglected Tropical Diseases project, and our role is to address gender equity and social inclusion related issues affecting program outcomes to support the project in reaching the last mile. Next slide, please. So in the next 10 minutes or less, I'm going to focus on a general overview of gender equity and social inclusion related issues in the NTD program and how YHER is supporting the project to address those issues. So just a few points I'd like to mention before we start is that we're still facing, in general, we're still facing issues in addressing gender equity and social inclusion related issues because of the pushback and the need to bring more awareness to programs to address those matters. We still face issues related to like people's thinking that gender is somebody else's job or someone else needs to focus on it. But on the ACT to End Neglected Tropical Diseases project, gender equity and social inclusion is an integral part of the program design, implementation, evaluation, and also documentation. As we all know, these are issues affecting every one of us, women, girls, men, boys, hard to reach populations, ethnic and religious minorities, gender identities, persons with disabilities, and more. And we look at differentiated exposure and risk of diseases, access to and uptake of prevention and treatment, social norms, roles, responsibilities, behavior, and power dynamics. As NTD programs get closer to achieving elimination and control goals, efforts will shift to the hard to reach populations because we need to find ways to reach the most vulnerable. And gender equity and social inclusion, as I mentioned, is an integral component of the program, but we have also a sustainability lens. So we work very closely with our team focusing on health system strengthening to make sure that the programs are sustained after the project ends. Next slide, please. So why is gender and social inclusion important in reaching the last mile? I'm gonna just bring few examples here based on the 6 building blocks, the 6 system strengthening building blocks. The first one is the service delivery. So as we all know, at the service delivery level, even if access is available to all, we still face issues related to the decision making to access services, availability of funds among different groups, especially the women and the most vulnerable. But also there's an issue related to utilization of care that we need to pay attention to. Even if services are available, utilization is still a challenge. We still face issues related to non-compliance, issues related to taking medication, even if the service is available to all. At the human resources level, we are looking and considering issues related to the drug distributors who is providing care. And we look at women's participation in the process. We, globally, 43% of drug distributors are women. In this case, we're not looking at making it equal numbers of men and women, because in some communities, they prefer having a male distributor, in some communities, female distributor. In some communities, the program has both going at the same time to make sure that the clients receive the best care possible. We're also looking at leadership opportunities, like how many women are in supervisory positions, and that's important because we want to make sure that we achieve equity in this process. The availability of data is so critical. We on the project, all countries provide and report data disaggregated by sex and age, but in many other countries, even though disaggregation of data is possible at the community level, and we will hear from our colleagues later on, reporting at the national level or even beyond is still a challenge. And by not having that ability to analyze and look at the data from a gender and equity and social inclusion perspective, we miss the chance to reach the most vulnerable, because we still look at it in an aggregated manner. And that's a very important issue to consider. The issue of essential medicines, a clear example is the safety of preventive chemotherapy for pregnant and breastfeeding women. We still, we all know that ivermectin is not, for example, is not safe for pregnant and breastfeeding women, and we miss the opportunity to reach this important group, because in many countries, there is many years where women are either pregnant or breastfeeding because they do not basically space their pregnancies. So that's an issue that we need to think about. In terms of financing, in many countries, gender-responsive budgeting is available and is a policy at the national level, but then operationalizing it is a different story. Like, how are these gender-responsive budgets?
Issues that may affect users, but those issues that affect the users happen at multiple levels.
Sorry,
So
I think there is somebody else that joined this session, Amanda. Oh, thank you. So I'm going to continue here and move quickly. In terms of governance, we think about women's participation in leadership and policy making, because if we don't do that, then the design of programs and the implementation at the national level might be affected. Next slide, please. To address all these gaps, Whitehair came up with an innovative methodology called IDEAR. It stands for Identify, Design, Apply, and Assess, Record, and Expand. And I'm going to go briefly over this methodology, and please feel free to know more about it. It's on our website, and it's very easy to basically access. The whole idea here behind IDEAR is that it is based on the science of improvement, and we ask ourselves, what are we trying to accomplish? How do we know that the changes are documented? And then the most important question of it all is, how do we know that the changes that we're trying to implement are basically leading to an improvement? Because not every change that we implement to address gender and social inclusion related issues lead to an improvement. And this leads to another question that is important. When we design gender equity and social inclusion programs, we need to think about the do no harm. So the first step of idea is to identify those gender and social inclusion gaps through either conducting a quick desk review, conducting gender analysis, conducting qualitative assessments, quantitative assessments. This is the most critical step in identifying and addressing gender equity and social inclusion related gaps. And we will hear more today about the I in IDEA, because we conducted a global desk review, and we conducted specific gender analysis at the country level that you will hear about from my colleagues. The next step is designing programmatic interventions to address those gaps that we identify, and then applying those solutions and assessing. So today we will hear about the identify, the design from Uganda, and then how they are applying those solutions and assessing them. And then the last two steps are related to recording knowledge and how the implementation of those activities are reaching the goals that we want to reach. And then we expand beyond just the limited area where we tested those solutions. So this is in brief what IDEA, basically the methodology is. Next slide, please. So we conducted, as I mentioned just a few seconds ago, we conducted a global desk review, which was, the goal was to shed light on gender and social inclusion dynamics and how it affects the NTD program, how it affects health system strengthening programs at the global level. And the whole idea was to look at gender norms, roles, and how they affect the health system, and then how they are affected by the health system. I'm going to give examples. We looked at 5 diseases because the project focuses on 5 diseases. We looked at how gender affects trachoma. For example, child care and caregiving increases women's risk. Women account for basically 86% of the global trachoma cases. I'm not going to go over all these because you have them on the slide, and I know it's a busy slide, but we wanted you to have them so you can look at them. And we have the full report on our website if you'd like to reach it, or you can send us an email and we can share it with you. In terms of, I want to mention one thing here related to treatment. For example, trachoma. Even though we know Zithromax is safe for pregnant women, but in some countries it is not used. It is still viewed as a risk for pregnant and pregnant women, and for breastfeeding and pregnant women. And that's a challenge we need to think about. We assume that since it is safe that everybody will take it, but we discovered that at the country level, that's not possible. I mentioned ivermectin and how it is not safe. In terms of lymphatic filariasis, in some countries, hydrocele in males men may not seek treatment because they might feel that it is a perception of masculinity, for example. So these issues we need to think about when we address neglected tropical diseases and when we design the programs. Next slide, please. Here we have examples about soil-transmitted helminthiasis and schistosomiasis. So for example, the lack of wash at schools put children at higher risk. Infertility caused by hookworms for women needs something we need to think about. In terms of schistosomiasis, it is so critical, and we found so many issues related to schistosomiasis among women, and how it compounds and puts women at higher vulnerability, for example, for infertility, increased risk for HIV, and we need to think about the linkages between NTD and other diseases as well when we address them. Next slide, please. So here are some of the identified vulnerable groups by country. And when you hear from my colleagues from Nepal, Tanzania, and Uganda, and Tishale will share some of the thoughts in Ethiopia, here are the groups that we still need to focus on. In Nepal, for example, some religious communities, some castes, some urban populations are not reached. Either, you know, the program is trying to reach them, and the program is striving to reach them, providing service, but then the challenge is with these groups utilizing the service. We still are facing this issue in Nepal, and Raman sir will share with us some of the thoughts. In Tanzania, there's a challenge reaching out of school children, for example, reaching men who we provide services for outside of the working hours. In Uganda, we will hear from Mike about how we are reaching pregnant women. We still have a challenge with mobile population and migrant population, and also with people who abuse alcohol. And in Ethiopia, we have a challenge with migrant populations. Next slide, please. So what else do we need to know? Basically, we need to know that gender, social, and cultural norms heavily influence health access, but there is a dearth of qualitative and quantitative data describing NTD exposure, susceptibility, which is important, and barriers to treatment. We need to think about that. Country level information about some of the social circumstances that further expose people who we serve to certain NTD. We need to know more about that. We need to know about NTD drugs that are safe for pregnant and lactating women. I cannot talk enough about this, the importance of this, and how we can improve coverage among men. Those are issues that we still need to think about. I mean, I just briefly mentioned those 4 areas, and then when we go over the country presentations, I can tell you more about that. As I mentioned earlier, next slide, please, Amanda. We on ACT to End Neglected Tropical Diseases project, we work together with the sustainability team in parallel to make sure everything we do is sustained and institutionalized, and that's very important. So from the get-go, even when we conducted our gender analysis, we worked hand in hand with the sustainability team when they conducted sustainability assessments. So we incorporated questions in the sustainability assessment that are gender equity and social inclusion related, and we did the same in our analysis. We incorporated questions related to sustainability. In some countries, we conducted the assessments at the same time, and we conducted interviews jointly, like for example, in Tanzania. And then the plans that we develop when it comes to addressing gender and sustainability issues are done together at the same time, and we implement and monitor and share learning together. So to do that, we developed a gender equity and social inclusion strategy at the project level. The first, we have four approaches, the strategy. The first one is to develop the capacity, local capacity, in how to address gender equity and social inclusion related issues. And this is very, very important, and we will hear from our colleagues how we are doing that. And then we are integrating gender equity and social inclusion across all program activities, as I mentioned, from the design to the documentation to sharing learning. And then we will document and share learning across project activities at the country level. And that's important because what we learn in Tanzania might apply in Uganda, or what we learn in Ethiopia might apply in Tanzania, but might not. And there is also a cross-regional learning that we are sharing across the project. And then we scale, institutionalize, and sustain, and share those learnings at the global level. I want to make sure that I mention the do no harm. In everything we do, the do no harm is at the core of our thinking, from the design phase to the documentation phase. Thank you very much. Tishali, back to you.
Yes, thank you so much, Dr. Charoub, for briefing us the general overview of gender equity and the social inclusion, and also for briefing why gender and the social inclusion is so important in reaching the last mile, and also other important points. Now we'll hear from the three countries, Nepal, Tanzania, and Uganda, existing experience and related gender equity and the social inclusion. And in each presentation, we will see different perspective. So let us start from Nepal. Mr. Raman, he will share with us the Nepal's commitment to address gender equity and the social inclusion in NTD from the desk review that they made from Nepal context. So the floor is open for Mr. Raman.
Okay, thank you, Tushale. And I am Dharampat Prasad Raman, Chief of Party, USAID Activist Program in Nepal. And as I would like to present here what we have done in Nepal, or RTI is done in Nepal from desk review, the findings from desk review. In-depth analysis has not been done till, but findings from desk review are here, which indicates that still we have some gap, and that has to be addressed for the sustainable control and elimination of NTDs in Nepal. Okay. So first thing I would like to share with you is the political will in institutionalizing GESI and NTD program. Nepal has made, as you can see, it is essay from the Director General of WHO, while Nepal eliminated the trachoma in 2018. That was the first Asian country to eliminate that. So it shows the political will. There is political will, and it continues with us in Nepal. And government is taking the leadership. Good thing is to note here is that all NTD control elimination programs in Nepal are implemented under leadership of the government and through the government system. Okay, then other thing is that in 2012, till 2012, Nepal was collecting only desegregated data, sex desegregated data, total data till 2012. From 2012, currently desegregated data by sex is being collected, and now government is planning to collect desegregated data by gender, caste, and ethnicity on the incidence and treatment of various diseases. So it's underway, and the National Health Management Information System is creating fields, and in near future, this data will be collected. And I believe it will help in proper analysis of the proper gaps, existing gaps. Next slide, please. Okay, so as I already mentioned, in 2019, RTI Activist Partner, we have already did the desk review of what is available in Nepal for gender equity and social inclusion. One thing to note here is that with the new constitution, gender equity, social inclusion is inbuilt in the constitution, and rights of disadvantaged group or those who are left are already there. So it goes through all activities of Nepal, development programs, political structure everywhere. So, but what here the findings are, women in Nepal have limited household decision-making power, especially regarding healthcare. This is the finding which from the desk analysis. It has improved a little bit, but still the gap remains. Nepal conducted DHS, Democratic Health Survey, in 2016, and it found that more than 40% of women were not allowed to make decisions regarding their own health care. Mostly it was when they got the pregnancy and they have to make the deliveries. So preparation for that. Gender, caste, and ethnicity-based social exclusion was also noted. Still, it exists in Nepal. So based on the caste and ethnicity, some social exclusion is there. It has improved by law. Law is there to eliminate that. But in practice, still some challenges remain. Next slide, please. Okay, I continue with the desk review findings. More than 8 in 10 women and 83% healthcare problems assessing healthcare themselves for reasons beyond limited decision making. Even they can make the decision making, due to the geographical position of Nepal in the world, we have difficulties in traveling, and you have to travel longer hours to reach your nearest health facility. So it happens in Nepal, and it's mostly with the women. They face a lot of problem. 68% do not want to go to the health facility alone because it is far away. They have to travel alone, and the violence or other threats, maybe they are on the way if you have to travel for a long time. 55% are worried about treatment costs. So now the Constitution has made the health as the human right. So that's it has improved, but still there are some costs which goes beyond, and the out-of-pocket cost has to be done. That's why there is some worry about that. 53% are worried about the distance they must travel, as already mentioned here. 25% of women are concerned about getting permission from their partner or family go for. So usually, women are not, there is some restriction or due to pediatric society practices in the social society, they are not easily allowed to go alone for the health care. Next slide, please. Okay, in conclusion, with this slide, I would like to share with you that the findings which I presented from the desk review indicate some gaps. Nepal has taken the ownership of the program, especially the lymphatic filariasis elimination program, and all MD activities, the mass drug administration activities are now being implemented with the government fundings. Government has tried to adopt or different approaches as is developed with the experience from the learning, but still there are some challenges remaining in Nepal, where Nepal is facing repeated failure of pre-task or task. So, and that is due to the low compliance or the low participation of some identified or a special ethnic guest or the group. That's why GESI analysis is planned now in the 3 districts of Nepal in province 5, which you can see here marked there. And these are the areas where Nepal is facing the challenges of non-compliance. And we hope that with this analysis, Nepal will be able to, or we will be able to get some indicators to develop the strategy for gender inclusion and social inclusion, which will help us to reach those communities or people or ethnic groups who are not participating. And by that, Nepal will be able to achieve sustainable elimination of NTD program. So by that, I would like to conclude here.
Thank you so much, Mr. Rahman. Yeah, we are proud of your accomplishment. You have eliminated trachoma, leprosy, visceral leishmaniasis, but you are still need to have focus or give attention to populations that are self-isolated or reluctant to receive services. So now we'll hear from Dr. Easter, who will share with us the experience in Tanzania, how they are addressing gender equity and the social inclusion in their program. So please, Dr. start your presentation.
Thank you, Teshale. Can you hear me?
Dr. Esther, I think let's see if Dr. Wema's internet is able to withstand, and then.
Okay.
Thank you, Teshale. I hope everyone can hear me well. Yes. From Tanzania, picking up has gone a further and how equity social dynamics could affect NTD treatment, and this and in several aspects and also using different methodologies. And we can see the results in the next slides. Let's go. Next slide, please. So these are the 3 sites where the analysis were done. As I mentioned earlier, we did focus group discussions with different people in the communities, male, females, mixed groups with male and females, people with NTDs, community drug distributors and teachers, but also key informant interviews with health system people, district medical officers, NTD coordinators, both regional and district level, and also other healthcare workers who are the frontline healthcare workers. Next. Next. So I'm just going to present sample findings out of a lot that we got from the analysis. This is from Community Mass Drug Administration, and these are some barriers, trachoma and LF drug MDA uptake. We see that most of the boys and men as well, we can say that they will be missing MDA because of their work, the nature of their work. At times they'll be out for leisure activities, at times they'll be migrating for other work somewhere else outside home. But it's a tendency that most of the time men will have a low desire to interact with the healthcare system. We did found something specific with girls or women, unique with community MDA, but we have children with disabilities who are facing great challenges, especially they are not able to reach the central distribution points, but they can be reached at home anyway, but it's hard for them to get the distribution points. So if someone is not taking care of that, meaning they will miss the drugs. Down to the community, we find sometimes family members will just be out for some other reasons. For example, they can go to neighbors, they can go to other places as well. But we have these mobile communities like pastoralists who will move from one place to another. And some homes, we find them, they're very far from where, from which the CDDs cannot really reach on foot. Next slide. Next slide, please. Next slide, please. Next slide.
Sorry, Dr. Wema, would you like to be on the workforce?
Thank you very much for the next slide. So other implementation challenges, the other slide with implementation challenges, we have found that from the CDDs themselves, they had reported several challenges that the CDDs themselves had issues to do with education. Community members, they are saying that the education provided by the CDDs, it is not enough, so it is not really supporting uptake. And also, at times, the community drug distributors will leave the preventive chemotherapy at home. But we know that not always that the family members will take these drugs. When you leave them there, they will just leave them there as well. But also, the selection of community drug distributors is supposed to be done by the community members by themselves. If they don't understand how this process have gone, they will always resist. So that has been also a challenge. But they were facing also the problem, the CDDs, they were facing the problem of transport. The geographical issues are also a problem that other houses are diverse and they're scattered. So the transportation is an issue to them as other houses are in remote areas. And they also receive kind of incentives, but it is not sufficient for them. But also they aired out that they would like to have more days for training that will make more comfortable providing the services in the community. Next slide, please. Next slide. So how are we institutionalizing GESI right here in Tanzania? It is something very good that we have a buy-in from the government, the ministry people. They have really agreed with us to have this on the table. And basically at the national level currently, there is this an ongoing process where NTDCP and the Ministry of Health as in general, they are writing their NTD sustainability plan. and it is just at the level of draft, it is still ongoing, but we are believing that this, when it is complete, it will guide national neglected tropical disease health system strengthening activities for the next 5 years. But as the country we have been having existing gender equity and social inclusion supportive structures, taking into the bigger picture, the Tanzania National Health Policy, the current one, 2017, it is very sensitive for gender, and it is putting more attention in the to the quality of health services as the country is pursuing towards universal access. And so it recognizes gender integration as a priority of health and other health related sectors by having an objective. There is a specific objective that is saying to enhance gender equity and equity opportunities to access health services. So this is a great achievement and a great opportunity where GESI can land on. But the ministry itself is having a specific department where they are hosting social welfare and gender issue. Apart from that, as the government itself, it has established a lot of gender desks in different levels in the public system. But also we have a sector-wide approach as where we are having technical working groups under it, and there is a specific technical working group that is also hosting gender issues together with social protection issues. Next slide. Next slide. So these are our next steps that we are planning now to build the local capacity, where we are going to have champions and experts who will take gender and social equity interventions integration down to the district level. We are trying to train them, and we are planning to support the ministry so that they can be able to train them. And this will be very great achievement because we will have a local capacity. But also we are planning to support the ministry as well to test some kind of intervention packages in one of the districts that we have highlighted together with them.
I believe we
Thank you. Thank you. Said the packages, we are going to scale it up to other parts in the country, but also as we see our framework later on, we're going to document the lessons learned and also learn and share about what we got out of it. So in conclusion, I would say that gender equity and social inclusion is really, really key in achieving NTD goals of elimination and control in our country. And also it requires really building the local capacity so that we can be able to have our experts who will take it forward, but engaging key stakeholders all the way from the national level down to the community level. Thank you.
Thank you so much, Dr. Wema, for sharing with us how Tanzania is addressing gender equity and the social inclusion in the NTD program, and the importance of institutionalizing this program for sustainability. Here in Ethiopia, we are also working on the NTD sustainability plan that would help in reaching everyone. Now we want to hear from Mr. Mike Mkrane about the experience in Uganda, where he will be discussing and translating the national NTD sustainability plan into action at national and district level. So please, Mr. Mike, can you present the experience in Uganda? Thank you so much.
Thank you, Teshali, for giving me this opportunity. Good morning, good afternoon, colleagues. I'm called Mike Mukirani. I'm the Health System Strengthening Advisor for ACT East, based in Uganda. Next. Just like it was presented that there was a global desk review, there are recommendations that were made for specific countries to conduct gender analysis, and Uganda was one of them. Like Tanzania, we conducted GESI, gender equity and social inclusion analysis in Uganda. with a number of objectives, which were identifying Uganda-specific gender equity and social inclusion gaps, challenges, and opportunities. Also providing an insight into how NTDs are affecting different populations, but also learn how gender dynamics impact on neglected tropical diseases exposure and mass drug administration access and uptake, with a view of designing a strategy that will inform programmatic and health system intervention activities in Uganda. This analysis was conducted in the northern part of Uganda because of the prevalence of neglected tropical diseases in this area, but because the neglected tropical diseases control program is based in Kampala, we also had interviews in Kampala at the headquarters. And we had focus group discussions where we divided the males alone and the females alone, then a mixed focus group discussion group. And we also had one with people with NTDs and community medicines distributors. And then the key informant interviews were with the neglected tropical diseases control program coordinators and program managers, the district health officers, district health educators, the NTD focal persons in the districts, the mass drug administration supervisors, health providers, and then teachers. And the total number of participants for this analysis were 312. Next. Now, as you saw in the objectives, we had an objective that was looking at sex and gender-related barriers to MDA access and uptake. And these were some of the findings that came out of these focus group discussions. When we met the males, we found out that the barriers to access MDA were around the men working outside their home. They could not be reached because they are not in the homes by the time the community medicines distributors are moving around the homes, which was an issue that these people really highlighted out. The other one was the evening leisure activities where men participate a lot, such as football. I know the men in this room know that we go for football and other leisure activities which lead to inaccessibility when the program is taking place. And then most of them were working outside their homes, migratory work, like in mining fields, or they're grazing somewhere outside their homes. This was also found out to be a barrier on access to MDA. Then barriers to uptake, the biggest factor was actually found out to be alcohol. The men were taking a lot of alcohol, and this would make them not accept to take the drugs when they are drunk. And more so, when they take this alcohol, they think the drugs are going to have an effect on them, so they could not take the drugs. This alcohol also affects their health-seeking behavior. When they are drunk, whether they have a problem, they can't go to the health facility. The other barriers to uptake were on perception that the services are just for women and children. So the men think it's the women who are supposed to go for services. Looking at the other services that are given to the community, like immunization, they see the women taking the children and the men are not involved. So they perceive that even MDA services are for women and children. Then not understanding the fact why they should take preventive chemotherapy when they are not sick. They think you take drugs when you're sick. So this was also another barrier to uptake. And of course, long waits where there are sentinel sites for mass drug administration. The men will not want to wait for long because it is a first come, first serve basis. So if you come late, you have to wait on the line. And then also the perception that mass drug administration drugs affect their libido was also a big factor in uptaking mass drug administration. When it came to the women, as you saw in Tarub's presentation, the women don't access drugs when they're pregnant because some of the CMDs and health workers still think, for instance, Zithromax is not good for the pregnant women. Ivermectin is not good for pregnant women, and it has side effects and teratogenic effects. So they don't give them the drugs, and the women miss out on the drugs when they are pregnant and when they are breastfeeding, which is a very big factor in accessing mass drug administration. Then barriers to uptake, when we know that poverty is part of the problems, is part of the issues that are mentioned in NTDs. So the CMDs, the community medicines distributors, will reach the communities when they are hungry and they cannot take the drugs because because of the side effects that they have had some time back and we've not explained to them. So this was also a very big factor. But something interesting and striking that we got out of this analysis was that the power to determine on when the women should take MDA was independent of their husbands, which was a very, very good finding, because we know that men wield a lot of power against women, and to an extent that they can refuse them to take MDA treatment. So that was a very positive finding. And then when we combined all the two groups, the males and females, yes, some of the issues above came up, but then there are specific issues that came out. And one of them on as a barrier to access was that the urban and educated population was actually a hard to reach group for the community medicines distributors, because they cannot be able to convince them. These ones are educated, they look at the community-based distributors as people who are not well educated. And these are in gated places where the CMDs may not be able to access. So it was a very, very big barrier to mass drug administration. Then, of course, as educated people, they were mentioning previous experience of severe side effects of NTD drugs, which was a barrier to uptake. Next. Yes, as a country, what process have we gone through to mainstream and institutionalize GESI in national activities? We know that as Act East, we are supporting the government of Uganda to do the activities of control, elimination, and eradication of NTDs. So the government of Uganda has put in place policies and strategies that support gender equity and social inclusion initiatives in Uganda here. And some of these documents, policies, is like we have the Vision 2040. Vision 2040 is actually trying to ensure that in our programming, in the government programming, in different sectors, gender issues should be having policies that favor them. Then we have the National Equal Opportunities Policy that came out in 2006, which also advocates for gender equality and equity issues to be included in all programming of ministries and other sectors. Then the Equal Opportunities Commission, which was established by Act of Parliament. This one vets the budgets of sectors to ensure that gender issues are embedded in there. And when they pass a document, they give a certificate to show that this document really caters for gender-related issues, and that's when Parliament can be able to pass this budget. And then the Public Finance Management Act, which also looks at gender-related issues in there. Then the NTD control program has a master plan, and this master plan has one of its principles, which is the right to health with due attention to gender and equity access. So these are part of the provisions that the Equal Opportunities Commission look for in plans before they are passed. And then gender mainstreaming is a very important aspect there, which is mentioned in the master plan, that gender plans and activities, the NTD plans and activities should have the genderless in there. Then disaggregation of data by age and sex is a must. And then targeting the marginalized people, such as people with disabilities, the migrants, and the people who are working in the fishing industry. Next. And then we have just concluded supporting Ministry of Health develop the first ever Uganda NTD Sustainability Plan 2020-2025. In this sustainability plan, gender issues have been integrated in all the functional areas like Taru presented. In all those functional areas, the building blocks of the health system, gender issues have been integrated there, and this sustainability plan is going to be used by all the implementing partners as they are implementing activities. So it gives us hope that we are moving forward in terms of integrating gender into NTD programming. And in this sustainability plan, we have included gender sensitive indicators, which indicators were not being tracked before. This will help us to see, are we moving well or we are having issues? And then also prioritization of resources to identify and address GESI issues. Next. How have we moved to date? After carrying out the gender analysis and understanding the issues, we conducted a training for national TOTs who will cascade gender and equity and social inclusion training to the district and sub-counties. These trainings were actually multi-sectoral. We had other partners included. We had people from the national level in these trainings and also the district level participants, so that we can have ambassadors across board that can push gender related issues. Then we integrated gender equity and social inclusion into the Uganda NTD Sustainability Plan, as I had mentioned earlier. And also we have integrated this into mass drug administration activities through training of central supervisors. Right now we are having a mass drug administration activity going on, and all those issues that were identified in the analysis are being catered for in this round of MDA. Then we have included gender-related issues in activities into the NTD control program FY work plan, so that as we are implementing, we know we are having a gender lens in the activities that are being implemented by the government of Uganda. Next. We conducted a disease-specific assessment in the districts with gender equity and social inclusion integrated throughout the process. And this is where the issue of alcohol actually came out very clearly in the DSA. And as we plan for the next mass drug administration, we put solutions to these challenges. And then we held district preparatory meetings for rolling out mass drug administration, which included GESI as a key component. All this that we were doing it in order to create ownership both at the national level and at the district level, so that we all move at the same wavelength. Next. Next. Yes, what are our planned next steps? We want to ensure that the work and achievements to date are sustained. We don't want to fall back and go back into a square where we see all the achievements that have so far been reached by the Ministry of Health falling back. And then we are also going to integrate gender equity and social inclusion into all MDA training materials at country level here, so that the subsequent MDAs, we know that the materials are catering for gender-related issues. Then we are going to cascade gender equity and social inclusion training to the sub-county, to the sub-district level, so that at the district level and the sub-county level, we know that people understand the concepts and how they can be able to apply them in order to improve NTD programming. Then sensitization of health service providers on gender equity and social inclusion integration into their activities, because we want to move towards integrating NTD programming into the routine healthcare programming. And if we are to do this very well, the health workers should be aware that gender-related issues are very key. Then inclusion of gender-sensitive indicators into health management information system and district health information system too, so that the Ministry of Health can be able to track the progress at the click of a button. And then also including gender-related issues into the advocacy strategy, which we are going to develop in FY 2021, but also as Act East, provide ongoing technical assistance to the Neglected Tropical Diseases Control Program for integrating and mainstreaming gender into their interventions and popularizing the existing gender-related policies and strategies as mentioned above, because we see that these ones are made at the central level and they don't disseminate them at the sub-district level where the implementation takes place. Now, what message do I have for us all? Uganda has made strides in controlling and eliminating NTDs. But if we are to sustain these achievements, we need to look at the gender lens, because we are still seeing pockets and gaps in gender equity and social inclusion within NTD programming. That's why we have the sustainability plan. This sustainability plan is a multi-sectoral document. We need to work together as different sectors, Ministry of Gender, Ministry of Education, Ministry of Water, the community itself, and speak out on GESI issues whenever we get an opportunity and join the fight to eliminate NTDs in Uganda. Thank you very much.
Thank you so much, Mr. Mike, for the detailed experience of Uganda. I look forward of learning during the panel discussion, the implementation process that you have taken. So I think as a reminder to the participant, please, if you have questions, please use the chat function and you can drop your questions so that we can reply them later. So I would like to appreciate all the presenters for their excellent presentation. Now we'll go into a panel discussion where we will be able to learn more about the Great Country Programs and the work to date in the 3 countries. After, we will have time to answer questions from the audience. So please send your questions via the chat facility on the virtual meeting platform, which will be monitored by Amanda. So let me first start by asking Dr. Wema about the gender equity and the social inclusion findings. Were there difference in gender equity and the social inclusion findings for the different diseases? How did you focus your LF and the trachoma interventions? Can we start from by reply from Dr. Wema?
Yeah, thank you, Tashali. Well, much as we have seen the barriers that we face with LF and trachoma community MDA, we also found some other issues to do with school-based MDA. We understand that we have a free education here, but a few parents, probably a few I would say, will not comply to the policy, and it will be a problem that their children will miss the drugs. But coming back again to lymphatic filariasis and trachoma, we understand like lymphatic filariasis, it is a disease that stays for long before it shows the disabilities. So the disabilities, when they surface, it's really a problem to women. You understand that women are carrying a heavy burden in the family. And if they get problem, first, they will also be affected. For example, in issue of marriage, are they going to be married? And if they are married, they are likely to be left by their husbands. So it is also posing a challenge around women. And how are we focusing now? We know that in future, this is what we've been planning for FY21 as well, that in future, we need also to integrate now gender equity and social inclusion issues in the investigation of those districts which have failed the disease-specific surveys. Where they have failed is where we need to understand better why did they fail. And also, we also need to strengthen the distribution. It should be real door-to-door and real direct observed distribution. That's how we really need to focus, I think, in future.
Thank you, Dr. Wema, for sharing Tanzania's experience. It will be great to hear from Uganda next. Mr. Mike, can you share your thoughts about this?
Yeah, thank you very much, Teshali. Yes, in this exercise of gender analysis, we also found out from the community that the risk of trachoma is associated to poverty and location. And I agree with the other presenters. Neglected tropical diseases have been called diseases of poverty. And where the prevalence is high, then we know that the infection will also, the infection rate is also high. So this finding brings us to a conclusion that if we want to achieve MARCH and eliminate trachoma, then we should have deliberate targeting of the poor people and also the locations where prevalence is high. Then secondly, the risk of trachoma is also associated to lack of access to water. And we can see this in the data that we get. Water-stressed areas actually have high prevalence rate for trachoma. So this was also a good finding for us, which was disease specific. When it comes to the impact of lymphatic filariasis and onchocerciasis, we found out that it's a double burden on women as a result of their own infection or that of their husband. And an example that was given here was that whether a woman has a disease or it is the husband having a disease, they will abandon their wives. More so, the husbands will not be fulfilling their conjugal rights. And this is an aspect that brings issues of gender-based violence in the homes. So this is a double burden to the women. Secondly, in Uganda here, the women do a lot of breadwinning tasks in the homes, because as we saw, the men are out there drinking, they're in their leisure activities. It's the women who bring what to eat in the home. Now, when they get a disease like lymphatic filariasis or onchocerciasis, and with the effects of this disease, they will not be able to go and work. So this leads to loss of income in the home. And in the end, you'll find that they're being struck by poverty and hunger in the home. And for the other diseases, like soil-transmitted helminths, we also found out that there's low prevalence in men, especially in one of the districts where there are a lot of pastoralists. And this was attributed to the men putting on shoes more than the women in the homes. So you'd find that the men are actually not infected by soil transmitted helminths because of the fact that they can be able to put on shoes. Thank you.
Thank you, Mr. Mike. Very interesting to hear the similarity and the difference between the two neighboring countries. Mr. Mike, can you share with us what opportunities you have had to take gender equity and the social inclusion into the next level?
Yeah, thank you so much. One of the opportunities that we've leveraged is the multi-sectoral collaboration with other sectors, such as the Ministry of Gender, Labor, and Social Development, Ministry of Health, Reproductive, Maternal, Neonatal and Child Health Division, and other partners like World Vision and Ascend. When we were conducting our training and the gender analysis, some of these partners were invited and we got a very good insight from them, what is happening in their sectors. So this is an opportunity that we leveraged on to even achieve the milestones that I presented earlier. The other one is the governance and political will. You saw the number of policies and strategies that the government of Uganda has put in place. These policies are very favorable for us to move forward without any hindrance. And these policies and acts have actually compelled the other sectors, the ministries, to ensure that gender-related issues are integrated into the budgets and other documents produced by them. Then the other opportunity is the support of the political arm, like the parliament, like the district councils. There is affirmative action in these councils. So whenever there are committees that are going to be established, we know that the ratio of women to men should be this. So no one will dispute that. When you go and talk about that, say you're putting up a committee in the community for NTDs, the regulations and rules are very clear on that. So that's another opportunity. And then working with the subnational structures at the grassroots level, these are the district local governments. As I mentioned, you saw that in our training for gender equity and social inclusion, the districts were, participants from the districts were invited to come and participate. Now, this is one way of advocating for gender-related issues, because these people who participated in this meeting work as ambassadors in the districts where they operate. So when you go there, you'll find that the ground is leveled for you to bring in other issues of concern. Thank you.
Thank you, Mr. Mike, for the nice briefing. Now I would like to go back to Dr. Wema to hear about the opportunities leveraged in Tanzania.
Thank you, Tashele. I think we are not far from Uganda. Basically, we have a nice political will, as I mentioned earlier. We have the buy-in, and also going back to our national health policy, it also calls for gender integration in health and other health-related sector. That's a big thing to note. And also the other opportunity that we have currently is the ongoing development of sustainability plan. I am sure when it is ready and when it is endorsed, it will help us to ground gender-related, social inclusion-related activities within the program. And also we got a chance, as Mike has just highlighted in Uganda, when we were doing our dissemination meeting, after analysis and the sustainability assessment, we got a chance to have a sensitization with the high-level leaders, policymakers. We did a sensitization with them, and it was a nice opportunity that everyone could understand about GESI. I know it needs a lot of engagement, more and more, but at least we were able to have that engagement with them. We understand that by doing that, it is a platform for us to continue working with them to implement gender activities within the program.
Thank you, Dr. Wema. Mr. Rahman, you shared some experience from Nepal on the importance of the government's commitment to eliminate NTDs. What opportunities you have leveraged or plan to leverage to integrate gender equity and the social inclusion in the national program? For example, here in Ethiopia, we are currently working on the sustainability plan, and we are also thinking of using the sustainability plan as a reference for the third national master plan. We are also thinking of training decision makers, training or sensitizing decision makers about gender equity and social inclusion. So what opportunities have you leveraged or plan to leverage to integrate GESI in the national NTD program in Nepal? Can you reflect on it, Mr. Rama?
Mr. Tishale, it seems Raman sir is having maybe a connection issue.
Okay,
Oh, there he is.
Nice, okay. So thank you, Dr. Sally. In first place, I agree with Dr. Wama that we have to find out why we are failing in our assessments or the tasks or the surveys. We have to find out if MDA non-compliance is there, why it is there. There has been some findings and government has tried to address that, but still we have to go more in depth. Nepal has not set any milestone because we have not done the assessment at the community level. As presented in my presentation, we have selected 3 districts and we will do it. The opportunity is that with the new structure, the federal structure, Nepal has 3 levels, and the lowest level is the municipality, or we say the local government. They are fully responsible for the implementation, monitoring of the program. That's why this is opportunity. There is elected leadership, and there we can integrate gender equity and social inclusion strategies into the planning, because implementation planning or MDA planning, program implementation planning is done at that level. So that's the opportunity I see, and this is the way to go forward for developing their capacity to program with gender equity and social inclusion alliances for sustainable achievement of elimination and control of disease. So that's how I see. So it has created an opportunity. Policies are at the national level, provincial level, at the local level, but for the implementation, we can work more closely and we can empower, train them to go ahead to achieve the results, sustainable results.
Thank you so much, Mr. Rahman.
Thank you. That's from my side.
Thank you. I am curious, Mr. Mike, as we plan for the training in Ethiopia, now we planned in our FY21 a training for decision makers and also for mid-level workers, as well as for those at grassroots level. How have the training in Uganda helped to move the process of gender equity and the social inclusion mainstreaming forward? Can you reflect on this, Mr. Mike?
Mr. Mike, you are unmuted.
Mr. Mike?
Oh, okay. Yes, thank you so much, Teshali. Yes, as Uganda, when we conducted that training, if you saw in the presentations the gender mainstreaming process, you saw that we did the gender analysis and the sustainability planning consultation assessment in order to come up with a sustainability plan. So when we conducted the gender training, it helped us to come out with a gender action plan which had issues that we were to integrate into the sustainability plan. So it helped us to come up with a sustainability plan that has been informed by the Gender Action Plan, which was a very good plus for the training that we had. Then secondly, as I told you earlier, in this training, we had participants from Ministry of Gender, we had participants from World Vision, we had participants from Ascend. Now, we had participants from the districts. This was creating for us a common ground in terms of NTD implementing partners. How can we be able to move forward at the same level in terms of gender-related issues? So that was also something that the training helped us to achieve. And then, of course, the training was so good that the participants confessed that they were hearing of gender equity and social inclusion, but they didn't understand the concept so well to enable them to decide in their programming aspects. So when we went through this training, the participants were eager to go back to their different sectors and ensure that gender-related issues are integrated in their plans, which was a very, very big milestone for gender equity and social inclusion in Uganda. Thank you.
Thank you, Mr. Mike, for the nice briefing. Dr. Taru, do you have any final thought to share with us?
Yes, let me unmute myself. Can you all hear me? Yes, okay, so basically, thank you, Mr. Tishali, and thank you, colleagues from Nepal, Tanzania, and Uganda. It has been a pleasure listening to your presentations. I want to say a few final thoughts, and I will answer one of the questions since I am unmuted. So I want to pick up from where Mike finished his remarks about the importance of the training. It is so critical to build local capacity in how to address gender equity and social inclusion for all persons or all colleagues implementing neglected tropical diseases program. It's not enough to just have one person with gender specialty to do this work. It's important that everybody has a gender lens that they can apply to the program. The next point that I wanted to make is related to the importance of the analysis that we are conducting. So as we all know, and as we heard from our colleagues, the gender analysis that we conducted initially was to address the geographic and demographic components of the work that we're trying to basically to identify those gaps that we're trying to close. But we realize that it is critical and important to examine issues beyond the demographic and the geographic aspects. We're gonna now start focusing more on, in addition to geographic and demographic, the psychographics and the behavioral aspects to examine the issues affecting the groups that we're trying to reach with services, to know more about their interests, their values, their cultural beliefs. It is important and it is in fact our responsibility to dig deeper, to understand what those issues are, and to design programs to reach the last miles. And that's what we will be doing in Nepal and Ethiopia and Haiti in the next few months. And lastly, I want to mention the importance of data enclosing gender equity and social inclusion gaps at the global level. As I mentioned at the beginning of my presentation, countries are collecting data disaggregated by sex and age, but the problem is it's not reported at the higher level. And this is so critical and important. Now on our project, this data is reported, but globally it's not reported. So I wanted to just share those thoughts with you. Those are my final remarks. Thank you, everyone. I have a question from a colleague. Should I just go answer it because we only have a few minutes? Amanda, should I answer that question?
Yeah, I think so. Mr. Tishale was going to direct it to you, so go ahead since you already
Okay.
read the chat. Yeah.
All right, so I have a question from a colleague about our experience in conducting gender analysis in other diseases like leprosy or Buruli ulcer. Now, we have the experience, of course, because that's what we specialize in at YHER. However, on this project, we are not addressing those diseases. So if you would like to reach out to us after the session, we will be very happy to share with you some of the tools that we use. But on this project, we're not addressing leprosy and Buruli ulcer.
Thank you so much.
Mr. Tishale, we have a question, I think, from Nepal, but go ahead.
Yeah, there is also one question that Mr. Raman can react on it. Yeah.
Yeah, I can address that. Thank you, Tishale. Of course, there is, just I want to answer the question, there is some provision or legal provision by constitution and by the Ministry of Health and Population strategy for GESI, gender inclusion and social, gender equity and social inclusion strategy, that all programs are at all level should consider GESI component, gender equity and social equity. And one thing is that it's easy and it will be more acceptable at the community level now, because elected leaders are responsible to their community, are responsible for their health. They have both the authority and responsibility to ensure good health of their community and their voters, their people. So as in the question has been asked, there is good opportunity and it will be more acceptable at the local government level, subnational level, where program implementation responsibility remains. Thank you.
Okay, thank you, Mr. Raman. I have also one question regarding about gender equity in the social inclusion assessment in Ethiopia. It says, while the country is the epicenter of many NTDs, there is no sufficient effort on integrating gender equity and the social inclusions. Why it's too late and unable to start GESI? Frankly speaking, on the second national master plan, it says women and the children are affected by NTD, and it didn't say much about gender equity and the social inclusion. But with the NTD sustainability plan, we tried to identify priority areas that need to be addressed, and at the same time, we need to see them in the eyes of or in the lens of gender equity and the social inclusion. And we are also thinking of using the NTD sustainability plan as a reference for the third national master plan. For your information, currently, Federal Ministry of Health is working to outsource the third national master plan for consultant firms to work on it. So that firm will be using the sustainability plan that has fully addressed the issue of gender equity and the social inclusion. Beyond that, WHO has done some sort of gender equity and the social inclusion assessment in agrarian area, but we are also considering of doing some sort of rapid assessment regarding gender equity and the social inclusion in pastoralist area and migrant area. And at the same time, we are also considering of training or sensitizing decision makers, as the person raised a question. Yeah, we are somehow late, but hopefully FY21 will be the time to address gender equity and the social inclusion related issues in Ethiopia. So thank you to the great audience and our presenters for a wonderful interactive session. For more information, please check the ACT East website, www.acteast.org. We have also written this site in our chat box, so you can check that. Thank you, everybody, for the nice panel discussion we had.
Thank you.
Thank you, Teshali.
Thank you,
Thank you,
Teshali.
everyone. And thank you to the
everyone.
organizers.
Okay, thank you,
Thank you,
everyone.
Thank you, everyone. Thank you.
audience, presenters, the great panelists from the
Okay, thank you,
conference.
Teshali. Nice to meet you. See you here.
እናመሰግናል።
እኛም እናመሰግናለን። Thank you.
እሺ